Hello everyone, this is Dr. Shamama, and today our topic of discussion would be infections of the central nervous system. So this is a very interesting topic, and that's very fascinating for pathologists when we see infections and organisms under the microscope. So this is going to be a lot of fun. So let's start. This was my presentation during my rotation in neuropathology department at University of Washington. So these are gonna be the overview that what would be the points we will discuss in this video. So this is the fourth video from our series of infections, and the topic of today would be toxoplasmosis. It's basically caused by Toxoplasma gondii, and that's the topic of discussion today. So let's start with the scenario. It's an old male with history of mantle cell lymphoma. Status is like post R-CHOP therapy and now currently taking maintenance therapy of rituximab. Presented with a mechanical ground level fall. He fell down, and when he came to the ER, the finding was right cerebellar lesion. Continuing on with the possible evaluation. Imaging. So imaging came out and it shows a ring enhancing lesion which is 2 into 2 centimeter in the right cerebellum. So this is the cerebellum. Macroscopically, now how it can present macroscopically, it's either in acute necrotizing, organizing, or chronic abscesses, and the disease can be at different stages in the same patient, and it can coexist together. Like maybe one area it's an early disease, in the same little bit on the third fourth slide you see like a severe form of the presentation. So at different stages the disease presents in the same patient, and how it presents histologically. So pathologically, the parenchymal toxoplasma lesions, they have three distinct zones. So in the center there is an avascular zone of coagulative necrosis, and this is how a coagulative necrosis would look like on the screen. And then there is an intermediate zone outwards. So central is coagulative necrosis, intermediate zone where excuse me, where numerous organisms will be present, and the outermost zone is the one which has encysted organisms. Okay, and toxoplasma lesions, they do not have a capsule, so this is an important point regarding it. So moving on, toxoplasma cyst. And so what we would see histologically, so this is a slide, the slide of the case, and what we do see here is these are the cyst of toxoplasma containing toxoplasma bradyzoids within it. So this is how this higher power version of it looks like this whole encysted area with this small organism in it. This is also another more clear picture of how it would look like, a cyst with bag of all the bradyzoids, and low power, high power, and then further high power view. This is an important finding when we are suspecting that it can be toxoplasmosis. Another important point can be that in addition to the cyst which contain the toxoplasma bradyzoids, we can also have extracellular tachyzoids too, and these are how they look like on low power. Higher power, see these tachyzoids, but they're not present in cyst, they're just present extracellularly, like outside the cells. So this is another important finding of toxoplasma. Another third important finding is that it can cause fibrinoid necrosis of the vessel's wall, and this is how it would look under the microscope, which was seen in this patient. That see, this is a vessel and we see this grayish material within it, this grayish material. Here we also see this grayish material. This is basically due to the fibrinoid necrosis, and that is an important finding here. Now there is an IHC stain which uses toxoplasma antibodies against the virus, and that highlights the toxoplasma. So this was the fibrinoid necrosis of the vessel, and here these brown areas are the toxoplasma organism, which are the culprit that are actually causing the disease here. So IHC stain is also available for diagnosis. Now, Further on, wrapping up the whole case, now how, so we diagnosed that after finding the characteristic H&E findings, confirming with IHC. Now just a brief learning point of view, that what is the pathogenesis, how it occurs. So cause, I told, Toxoplasma gondii, it's an obligate intracellular parasite within the cells, with a propensity to infect the nervous system, and the definitive host are either domestic cats and other feline species, and it is acquired by consumption of undercooked meat or cat feces which contained the parasitic cysts in it. So this is how the humans acquire it. After it, what would be the clinical features, how it would present? In immunocompetent individuals, it's usually asymptomatic because their immune system is competent, of course. But some people, they can develop lymphadenopathy, although the protozoa, it do insist and remain dormant within the central nervous system, but symptomatic neurologic disease is quite rare to occur. However, in which patients neurologic disease would occur? Adults with some sort of any issue that is actually depressing their cell mediated immunity, and as a result, their body can't fight the infection, so symptoms are being presented, and that's mostly in AIDS. But the probability and the incidence of it is now being decreased with the use of the heart therapy, because AIDS is being treated and not that complicated enough that infections occur. So that's why. And how the disease occur in AIDS and any depressed cell-mediated immunity is the parasite which is actually dormant. That's get reactivated, and that causes the infection. So last point, how you treat toxoplasmosis. Ideally it's pyrimethamine plus sulfadiazine P plus S, but in resource limited areas or poor settings, where this combination is not available, in that case try methoprim plus sulfamethoxazole, that is used for as an alternate treatment. And that's all for today. So thank you all for your patience and for your attention. And I want to especially thanks my attending Dr. Child, who gave me this presentation and gave me all the archive slides he had. And then my fellows, Dr. Alex, Joyce, and Lucy. So thank you all of them. Uh, this is a nice Seattle uh, viewpoint image. I really like this click. I like photography when I'm free, so a nice clip of that. And this is Dr. Alex, basically very good neuropath fellow. So I met him later on during my name poster presentation, so it was great. Well, thank you everyone, and goodbye. And do just before saying bye, do share your feedback in the comment section, and do correct me out if I'm saying anything wrong. And if you have any suggestions for future topics which you wanna like to listen or make me videos on your lectures, do let me know, and feel free to reach me out. So thank you so much. See you in the next video. Bye. Take care.